I'm here to discuss about the nutritional management of the metabolic syndrome with chronic kidney disease. So we all know what is chronic kidney disease. We all know that the kidney damage for more than 3 months as defined or by structural or functional abnormalities of the kidney with or without decreased GFR is known as the kidney disease. And it has 5 stages based on the decreasing levels of GFR. I'm not going to elaborate more on the CKD, on its prevalence and causes, because we are not going to talk about CKD today. We are going to talk about metabolic syndrome, which is a risk factor for CKD. So here are some studies which examined the link between the kidney disease and metabolic syndrome, like a study in 2004, Shen et al. They showed the metabolic syndrome was an independent risk factor for CKD. They explained the association of metabolic syndrome and risk factors of CKD in over 6,000 subjects who participated in the 3rd National Health and Nutritional Examination Survey, and documented that metabolic syndrome was independently associated with risk of CKD. I'm not going to read all this out because most of my initial slides have been discussed by the previous speakers. So coming on to what is metabolic syndrome, I'm not going to discuss more elaborately in this also, because this we all have heard about metabolic syndrome today in the previous 2 lectures, that metabolic syndrome is a concept rather than a disease in itself. Its diagnostic criteria out of the 3 out of these 5. Now, I am coming directly to the risk factors, components, and just a moment. So coming on to the components of metabolic syndrome, that includes central obesity, dyslipidemia, high triglycerides, and low HDL cholesterol, elevated blood pressure, and impaired fasting glucose. Like here, it is a flow chart of the components and risk factors of metabolic syndrome, like how they are aggravating and contributing to CKD. That is genetic factors, intrauterine environment, environmental factors that are contributing to increased triglycerides, increased LDL, decreased HDL, hypertension, glucose intolerance, obesity, diabetes, and cardiovascular disease, which is ultimately leading to cardiovascular disease, chronic kidney disease. And all this is happening because of the mostly influenced because of the environmental factors that are unhealthy diet, calorie intake, and physical activity. What we are what we eat. What does it mean? Metabolic syndrome is a result of modern lifestyle choices, eating the wrong amounts and wrong types of food, not exercising, having too much stress in your life. All these are manifested by a series of events related to abdominal fat and body inflammation. So potential strategies for preventing the renal damage in metabolic syndrome are diet, oral hypoglycemic agents, lipid lowering agents, anti-hypertensive therapy, and resistant training of physical activity. Prevention. Why I have used prevention as the key? Because the good news is that metabolic syndrome is preventable, not curable, but preventable. So how can you prevent it? The simplest answer is to reduce body fat, particularly belly fat. The more complex answer is to change your lifestyle. You can make simple and easy but very impactful lifestyle choices like healthy eating and exercising regularly and reducing your stress level. Here are some researchers. I'm not going to read all this because it is all related to reversing the negative changes in lifestyle to present a strategy for overcoming metabolic syndrome. So what are the components of lifestyle that we can control? That is nutrition, physical activity, and behavior modification. And the components that we can't control are aging and genetics. Here are the recommended therapeutic lifestyle modifications. that is physical activity, weight loss, healthy diet, functional foods and nutrients, alcohol, salt restrictions, and how they affect and what is their recommended dietary allowances. Here are here is the same for macro distribution of diet, carbohydrate, fat, fiber, protein. But this is all for the general therapeutic management of metabolic syndrome, not with CKD. So to manage the manage the nutritional status of metabolic syndrome with CKD, we need to understand the nutritional management of CKD first. So what is the goal of nutrition therapy? Its goal is to attain and maintain optimal nutritional status, prevent net protein catabolism, minimize uremic toxicity, maintain hydration state, maintain serum phosphorus and sodium potassium levels, correct hyperlipidemia, modify diet according to comorbidities, and control the progression of the disease overall. Now, what is the assessment of nutritional status? How we can assess this? According to the guidelines, we use the ABCD method, the anthropometry, biochemical, clinical, and dietary method, and SGS scores and medication review, of course. Now, coming on to energy recommendation. Energy needs of patients with CKD are similar to those of healthy subjects. Energy intake of CKD patients tend to decrease because of the gradual onset of anorexia as GFR decreases below 25 ml per minute. The estimation of energy requirement is necessary for indicating the food needs of an individual. It is necessary to take the following into consideration, that is age, gender, type of activity, body size, body composition, physiological state, genetic differences, diseases, climate, and pharmacological agents. Here I have given a simple energy scale for food, that how much energy or calories carbohydrates, proteins, and fat are giving. Carbohydrates gives 4 kilocalories per gram, protein gives 4 kilocalories per gram, and fats gives 9 kilocalories per gram. Now the carbohydrates are a major source of energy. Calories are needed to maintain basal metabolic rate and to support physical activities. Adequate non-protein kilocalories prevent tissue breakdown and aggravation of uremia. Also, it enhances the use of protein in patients who eat low protein diets. Carbohydrates are of two types, simple carbs and complex carbs. Here you can see those in pictures. I'm not going to read those out. Now, the protein. Protein are the building blocks. First, we all know that, but so why protein is important in management of this? Because to control the nitrogen intake, nitrogen in order to prevent the uremic symptoms and muscle catabolism, at least 60% of ingested proteins must be of high biological value. Low protein diet is recommended for CKD stage 1 to 4 to improve uremic symptoms and slow progression of renal dysfunction. The principle is to restrict protein, but do not say no to protein. The proteins are of two types: the animal proteins complete protein and incomplete protein. Complete proteins are called incomplete because of they provide all the essential amino acids, and incomplete protein lack one or two amino acids. Complete proteins are of animal sources, incomplete protein of vegetarian sources. Incomplete proteins combined with milk and milk products to get we can combine with milk products to get the complete proteins. There are some pictorial representation of plant sources of proteins and animal sources of proteins, and some protein content in some common food. Now, Play-Doh. I came across this study of 2020, that is plant dominant low protein diet for conservative management of chronic kidney disease. It is the overview of plant dominant low protein diet for nutritional management of CKD based on the dietary intake of 0.6 to 0.8 gram per kg per day with more than 50% plant-based sources. Now, lipids and fats, they provide essential fatty acids, higher in calories than carbohydrate and protein. 20 to 30% of total calories should be from dietary fats. Saturated fats and trans fats are known to modify the serum lipoproteins patterns for those with cardiovascular disease. The fats are Fats are divided into three types of categories, that are unsaturated fats, saturated fats, and trans fats. Unsaturated fats are good fats, are said to be the good fats. They are divided into two, like polyunsaturated fatty acids and monounsaturated fatty acids. Saturated fats and trans fats are bad. Like, we need to avoid these. This is the combination of combination of oils in 1:1 proportion. We can what we can advise to our patients. It is taken from consensus dietary guidelines for healthy living and prevention of obesity, the metabolic syndrome, diabetes, and related disorder in Asian adult Indians, 2011. Now, coming on to the micronutrients, first is sodium. High sodium worsens hypertension and proteinuria. Sodium intake must be restricted to prevent hypernatremia and water retention in the body, that is edema. Less than 6 gram of sodium chloride, that is less than 2.4 gram of per day of sodium, not sodium chloride, is recommended. Low sodium diet doesn't have to be a bland one to enhance the taste. Herbs like cumin powder, mint leaves, curry leaves can be substituted, and do not take low sodium salt as it contains potassium. Now, coming on to potassium, it is an important mineral present in many foods. It performs many vital functions like regular cardiac rhythms and muscle contractions. Kidney is the organ that maintains normal potassium levels, and during diminished kidney functions, hyperkalemia is a serious matter of concern. Hyperkalemia can lead to heart attack in some patients. It is a must to keep close watch on potassium levels. Here are some high potassium foods and some low potassium foods which can be suggested to the patients. Now, phosphorus. Hyperphosphatemia is usually present among renal patients due to following reasons. As GFR falls below 20 ml per minute, the functional excretion of phosphate drops, leading to increased phosphate levels. Consequently, there is hyperparathyroidism, high calcium phosphate deposition in soft tissues. And inorganic and organic sources of phosphorus should be considered by including protein sources, and phosphate binders can be taken on advice of doctors. Here are some high phosphorus and low phosphorus foods that should be given or avoided. Now, calcium. As phosphate levels increases, that is hypophosphatemia, calcium level decrease, that is hypercalcemia. Calcium requirements increases for the patients who are on phosphate binding therapies. Usually, foods rich in phosphorus are rich in calcium. Calcium will be better absorbed in the patients who are on vitamin D analogs. Normal recommendation levels are 1,000 to 2,000 milligram per day. Iron. Dietary iron is affected by dialysis-induced blood losses, frequent lab testings, and impaired intestinal absorption. All this lead to iron deficiency, that is anemia. Therefore, oral iron therapy is recommended, which include iron-rich food and vitamin C-rich foods for its absorption. Now, fluid management. Kidneys balance the fluids in the body. In a normal state, water intake matches water losses. With decline in renal function, the body is not able to get rid of the excess water, that is called fluid overload. Salt and excess consumption of water are responsible for it. In CKD stage 1 to 3, urine output is generally normal. Fluids include all liquids and anything that becomes liquid at room temperature. For example, water, ice, tea, coffee, milk, ice cream, thin custard, juices, coconut water, soups, rasams, thin gravies and thin dals, buttermilk, etc. Some solid foods contain large amount of fluids such as porridge, thin khichdi, kheer. Juicy fruits and vegetables are also counted as fluids like melons, tomatoes, and sweet lemons. Except in edematous state, fluid intake of 1.5 to 2 liters are recommended. Now, some smart ways to control fluids. Like, you have to ask yourself whether you are thirsty or not. Usage of measuring glasses, cups, measuring glasses and cups, eating away from the heat sources, eating less salt, using ice cubes and ice chips or crushed ice whenever we thirsty. Now the fiber. Soluble and insoluble fiber decreases the gastrointestinal transit time, which improves insulin sensitivity by slowing carbohydrate absorption. Soluble fiber is preferred. As it binds to bile acid, it decreases absorption of cholesterol. Here are some examples of soluble fiber like barley, legumes, or particularly cooked fruits and vegetables, oats bran, vegetable seeds. Insoluble fibers that are wheat products, bran, cereals, psyllium, and plant sterols, which are most important, like soybean, soy products, soybean butter, or margarine, that can be given 2 to 3 grams to separate meals of the day. Now, to summarize all of that, this is the recommendation of macro and micronutrients of CKD1 kidney stage, kidney damage. The recommendation for calories are 30 to 35 kilocalories per kg per day, 35 kilocalories per kg per day for less than 60 years of age for non-diabetic patients, and 30 kilocalories per kg per day for more than 60 years of age. For diabetic patients, it is less than 30 kilocalories per day per kg per day. Carbohydrates are recommended 50 to 60% of total calories. Proteins are recommended 0.8 gram per kg per day. The patient should start with 0.8 kg per day, and the intake should be reduced to 0.6 per kg per day as GFR declines. Fats, total fats less than 30% of calories, saturated fats less than 10% of calories, and cholesterol less than 200 milligrams per day. There. Phosphorus is recommended 800 to 1000 milligram to prevent hyperphosphatemia. Calcium 1000 to 1200 milligrams per day, that is 1 to 1.2 grams per day, that means. Sodium less than 2.4 grams per day. Potassium 4 grams per day, that is 1 milliequivalent per kg. Water soluble vitamins and minerals as per the RDA. Now the recommendation for micro and micronutrients for stage 2, 3, 4, and 5 kidney damage with mild decrease in GFR to severe reduction in GFR. The energy intake is same, not almost, it is same actually. Carbohydrates are same. Protein recommendations are 0.6 gram per kg per day, and those who are unable to accept 0.75 grams per kg per day is recommended. Fats, phosphorus, calcium are almost the same, so along with sodium and potassium. Now, we need to modify the CKD diet as per the components and risk factors of metabolic syndrome. So I'll take one by one the complications of metabolic syndrome. The first one is hypertension. Weight maintenance if BMI is more than 25 kg per square. Restricted salt, that is the recommended amount. Restricted fat less than 15 to 20 grams per day of edible oil. To prevent hyperkalemia, limit dietary potassium intake, monitor fluid load. Target blood pressure should be less than 130 to 80, 130 by 80 mmHg. Cessation of smoking. DASH diet is effective in reducing the blood pressure in adults, but it is not recommended for CKD patients, as it is high in protein, potassium, and phosphorus content. Remove some. There are some tips for hypertension, like remove salt shaker from the table. Don't add extra salt to your food. Avoid saturated fats like vanaspati, ghee, egg yolk, etc. Foods to be excluded in the diet are salt. The recommended amount can be given. Baking soda, canned foods, processed cheese, meat, fish or chicken, egg yolk, soups, bakery products, pickles, sauce, chutney, namkeen mixtures, papad, dry fruits like almonds, cashew, groundnut, coconut, etc., and deep fried foods. So, as I have used this line previously also, that low sodium diet or low salt diet doesn't have to be bland. The use of the following is allowed, like the use of garlic, ginger, green chilies, hing, tamarind pulp, mango powder. These things can be taken as a substitute of salt. And chilies and such spices are restricted to avoid gastritis and acidity. Now, dyslipidemia. Dyslipidemia is common in diabetic nephropathy and a potential risk factor for progression of CKD. The target LDL should be less than 100 mg per dm. In patients with diabetes mellitus and CKD, stage 1 to 4 is less than 70 mg per dm. There are some this is the classification of low density lipoprotein and LDL cholesterol. I'm not going to read out all this out because it is taken from the guidelines ATP3 classification and the therapeutic lifestyle changes. The keywords here is the keywords here of diet, weight reduction, no alcohol, and correcting hyperglycemia. Now, cardiovascular disease, how the diet in cardiovascular disease can be managed. Of course, the maintenance of weight, reduction of energy intake up to 500 to 1000 kilocalories as per the ADA guidelines number 5. Main form of carbohydrate should be whole grains, low fat, dairy products should be taken. Fruits and vegetables low in potassium should be taken. Adequate omega-3 fatty acids are recommended. Dietary sodium is same as per the recommendations. Restricted fat, reduction of saturated fats, saturated fatty acid and trans fatty acid is recommended. Prefer mono unsaturated fats and oils. AHA recommends total fat should constitute 25 to 35% of total calories. Fatty acid intake should be can be modified easily by substituting canola oil, a blend that includes both omega-3 and mono unsaturated fats for vegetable oils. Increase in physical activity of moderate intensity is advised up to 150 minutes per week or resistance exercise for at least 3 days per week. Now, diabetes mellitus. Maintenance of blood sugar and body weight is recommended. Here are the target blood sugar ranges. Preference of whole grains, protein is 0.6 to 0.8. Soy protein diet or low casein diet lower urinary albumin excretion, which leads progression of diabetic nephropathy. So it is advised to take soy protein diet. Avoiding simple sugars, categorizing carbohydrates containing food based on their glycemic response, that is their glycemic index and their glycemic loads. Prefer low glycemic index carbohydrates, that is mostly complex carbs, and fiber. The recommendation for fiber is 14 grams per 1000 kilocalories by ADA, by American Diabetes Association, and it can be increased up to 35 grams. Now, dietary instructions for diabetic nephropathy patients or for diabetics: avoid simple sugars, avoid large meals at a time, eat on time and take medicines on time, split meals into 3 meals and 2 small snacks for the day. If taking insulin 15 to 30 minutes before meals, make sure you eat food after taking insulin, otherwise the blood sugar level will drop, that is hypoglycemia can happen. Carbohydrate counting, a fixed carb meal plan is helpful, giving the variety with 15-gram carb food exchanges. Sugar-free can be taken, except for the patients with phenylketonuria. Can take free foods at any time of the day, as per the advice of your nutritionist. The free foods are the foods that contain less than 5 grams carbohydrate per serving, that are these options. Practicing portion control plays a very important role in the progression of metabolic syndrome, like eating huge portions of kidney-friendly low values of specific nutrients Don't take too long to add up and yield kidney damage high values of those nutrients. Please calculate nutrient values roughly when you fix your plate and be logical in your approach toward the quantity that you consume. Work around your own palates, mix and match safe ingredients to rustle up interesting dishes, and try to design a weekly or fortnightly menu for yourself beforehand. Keeps the urges away, helps you stay disciplined while on a renal diet. Now, also, it is important to cultivate a habit of reading food nutrition labels when buying packed food, especially in context with the hypertensive patients and CVD patients. Nutrient levels are printed in descending order. There are absolute milligram, gram values, and percent values. These should be considered as per the reference intakes decided by your dietitian. For example, less than 5% sodium qualifies as low sodium, while more than 20% sodium is taken to be high in sodium. CKD patients are directed to choose low sodium varieties of food, but please be aware. Low sodium is often compensated with high potassium. So these must not be bought. Coming on to the second strategy. The second point in the strategy that we can control is physical activity. Here is the physical activity chart given by the consensus statement of diagnosis of obesity, abdominal obesity, and metabolic syndrome for Asian Indians, and recommendations for physical activity, medical and surgical management 2009. Here they have given the type of physical activity, its intensity, duration, and frequency per week. Now, tips to increase physical activities. These were the recommendations, but how much are they practical? Physical activity must be individualized on the basis of person's abilities and comorbidities. Before initiating, medical consultation is recommended for those with chronic conditions or those who are symptomatic. Inactive people should start slow and gradually to increase physical activity. Brisk walking at an intensity wherein an individual finds speaking difficult but not impossible is preferred. Initial mode of exercise, and as this does not require any special training or equipment, a total of 60 minutes of physical activity is recommended every day, which is like can be shortened to 30 to 45 minutes per day at least. Physical activity can be accumulated throughout the day in blocks as short as 10 minutes. Work-related activity should be encouraged wherever possible, like stretching, avoiding the elevator, standing desks, some quick yoga by your desk, small one-to-one meetings on a walk, etc. Dynamic yoga should be encouraged, but it needs more research. Stress management, some pro tips. Being more self-aware, mindful eating, adequate sleep, following a routine, avoiding isolation, time and money management, deep breathing and meditation exercises, going for a walk, smiling more often, finding hobbies, playing with a pet, limiting screen time and social media, not comparing your growth and yourself with others, setting realistic goals for yourself, filling your mind with positive thoughts and gratitude can be helpful in reducing stress. Can be useful in reducing stress. In conclusion, what we learned throughout that maintaining an ideal body weight is necessary, increasing physical activity is essential, limiting salt 5 grams per day or 2 grams of sodium or less is advised. Water intake should be 1.5 to 2 liters per day should be consumed unless otherwise advised by your physician or nutritionist. Free sugars should be less than 10% of total energy. Small frequent meals and intervals. However, it is not practical for everyone. Options should be provided to have either 3 meals a day or small frequent meals according to convenience. Breakfast is essential. Healthy snacks should be opted. Healthy cooking methods to minimize fat intake like boiling, steaming, roasting, grilling should be preferred over frying. Limiting alcohol consumption. Considering the food labeling, avoiding saturated fatty acids and trans fats, RUFA is beneficial. Mixing oils should be achieved. To mixing oils should be used to achieve fatty acid ratio. Omega-3 should be encouraged following a healthy balanced diet as advised by the nutrition expert. As per the disease and its comorbidities is required, moderation is the key, avoiding stress while eating and leaving the calculations to the experts is advised. So, in conclusion, it is not a diet, it is a lifestyle. So, what is the take home message? Take home message is the prevention is better than cure. And not only the prevention, why we need to ask ourselves and we need to educate our patients that why let the metabolic syndrome to set in the first place. So awareness in general population is required. Thank you.